Hi class, this is Dr. Reyes-Fournier. I'm doing the weekend wrap-up of week 5, discussing all of the treatment options for Julie, our heroin addict with pain. First of all, I got to compliment a few of you for pointing out that she's a heroin addict and she has chronic pain. This is a very important point in her case, mainly because if she has pain and she's a heroin addict, the rehabilitation is kind of difficult. Why? Well, because she's been using heroin to medicate the pain, and let's just say that she's using like a baseball bat to kill a mosquito. Okay, so finding a medication that's going to be able to treat her pain, that is non-narcotic, non-habit forming, is going to be very limited. In fact, with individuals who are addicts, when they do suffer pain, even we're talking alcoholics, who do suffer pain, and, it is usually suggested that they don't take anything for their pain, or that it's very mild, staying with the mild analgesics and, things like Advil and stuff like that, mainly because you don't want to introduce anything to your body that might trigger addiction, okay? I know many people in recovery who won't do anything for pain, and we'll stay with, the more holistic alternative treatments, acupuncture, things like that. And it's very limiting, and it's kind of scary when you consider, if they have, major medical issues, like or a surgery where they would, to tough out pain afterwards. So let's talk about these different treatments. We already spent a week talking about 12-step programs, so I'm not going to be discussing that. Let's jump to the pharmacotherapy, since I started there in the first place. For opioid addiction, according to NIDA, the National Institute on Drug Abuse, we use methadone. Methadone has been used since the 30s, and it was introduced as a means by which to control heroin addicts. Remember, opioid addiction actually started centuries ago. The use of poppies for pain medication like morphine and opiates, opioid. I can't even think of, I'm not even remembering the word now. Okay, so it's been centuries that people have been addicted to opioids. So methadone was created as a means to control the addiction. Because it's synthetic, and it was prescribed as medication. So people who are in methadone maintenance, who take methadone, who don't want to go back to heroin, take their doses, and they have to go to a special clinic to get their doses. The problem with this is that people did become addicted to methadone. And getting off methadone in many cases is less severe than heroin, but still, difficult. So it's usually suggested to combine methadone maintenance with treatment, but that's not usually what they do. Usually they just go on methadone maintenance and stay there for a long period of time. And then when they try to get off, they have to go through a detox process all over again. Buprenorphine, I'm sorry, language is not working with me today, is also a synthetic. It's a partial agonist, which means that you don't get the full high of heroin or methadone. Methadone, you got less of a high, but it fulfilled that need, the craving for heroin. You get less of a high with buprenorphine, and it stops you from getting high if you actually use an opioid. The same thing for naltrexone, which is also used in cases of overdose from heroin, as well as Suboxone, which I know many of you mentioned as well. The other point of using pharmacotherapies, especially with Julie, would be to find her some sort of medication to deal with her pain. Because unless you deal with the pain, she's going to keep using. So that is her main excuse for using heroin in the first place. So you want to take away the need for that. And now let's talk about group therapy. I want to be very clear that group therapy is not a support group. A support group is a group of people who have the same issues talking about their issues. Now, it sounds like group therapy, right? But that's not therapy. That's people supporting one another. So AA, NA, things like that are support groups. You know, you go to a hospital and you go to a support group for people who are dealing with cancer or cancer survivors or people who've lost a child. Those are support groups. Those aren't led by professionals. Those aren't led by counselors. The people who lead those groups aren't especially trained to deal with groups. Group therapy is a skill that a counselor learns. And some people are really good at group therapy and some people are not. It is a skill. It is an art form. There is a lot of work that goes into creating a good group. Why does it work? The group process works because it taps into our need to be social and to be around other people. Why else does it work? And in fact, in some cases, it's even more beneficial than individual therapy because you have multiple things happening at the same time. You have the professional counselor, psychologist, psychotherapist providing therapy in a group setting. Then you're seeing somebody else get their therapy and watching them go through their process. So they are modeling something for you. So there's two things there. You're hearing the therapy, you're seeing somebody go through a process. You watch their success, which is also modeling it for you, creating self-efficacy for you, and you feel like maybe you can do this too. It eliminates isolation. Whereas when you do like for those of you who went to actual physical groups, the ability to be social, especially for people who are in recovery, is a very important thing. Usually drug taking is a social thing. So their ability to go there, and be with other people like them who are going through the same thing is very powerful. So the difference is that most people just go home afterwards and they don't associate. Whereas in group, you're kind of forced to. You're kind of forced to work together on these problems and work together on these issues. There's 5 different kinds of groups: psychoeducational groups, which is where the therapist actually teaches the clients how to, to see their addiction. They're teaching them what addiction is, what are the processes of becoming addicted. They're telling them about their diagnosis, why they were diagnosed. They're telling them about how their thoughts create their behaviors. They're explaining to them, and they're kind of almost like providing them a training on understanding themselves. That's the psychoeducational group. Skills development group, how to communicate. You teach them how to communicate. Cognitive behavioral groups, once again, thoughts creating behavior, teaching them to identify triggers, teaching them to identify their faulty thinking that's creating this bad behavior. Support groups, different thing. It's different when you have a group of addicts who are having group and then they do their AA group, because then they run those groups a lot like you would a group and not like AA. Mainly because they are modeling what their therapist has modeled for them. Interpersonal process groups in general are feelings groups, and they're going to get into bad relationships, things that they've had to deal with in the past. I will be providing you this link, which is actually from a tip from SAMHSA, And that actually shows you the difference between a support group and an interpersonal process group. Relapse prevention. I'm going to skip over behavioral contracting. Most of you got the idea with those. Relapse prevention was developed in the 70s, mainly because we were just forgetting that people do that. That, when they're not getting treatment anymore. Oh, yes, I wanted to say, support groups are not treatment. Group therapy is treatment. Relapse prevention is a form of treatment because you're going to teach them. These are the signs of your relapse. Relapse is a process. You start relapsing months before you ever pick up again. So Gorski is the guy when you want to talk about relapse because he's the one that identified it in the first place. Once you have, these are the steps to relapse, and I will be providing you that so you could read that on your own. But these are the things for relapse prevention. You do not start relapse prevention until the person is sober. When the person is actually sober and they've actually been in treatment for a few weeks where you can pretty much see that they're no longer detoxing and they are starting to deal with their addiction. That's stabilization. We know this. Now we can start talking about relapse prevention. We assess them much in the same assessments that we do when we do intakes, and we've talked about those. Those will help us as the therapist identify possible relapse triggers and how they use their drugs in the first place. What started that? Then we start educating them on relapse. We tell them the signs of relapse. We explain to them that they need to be able to use introspection and look at themselves all the time. Question your behaviors. Many people walk around life their whole lives, never questioning what they do. Okay? This is not, first of all, that's not a healthy thing to do. But second of all, for somebody who's addicted, they can't live like that anymore. Okay? They have to be able to say, okay, why am I angry right now? Oh, I'm angry because I haven't eaten yet. And then when I get hungry, I get a little angry. Okay? Why am I being so pissy at work? Things like that. And identifying your feelings and constantly, just checking in on yourself. Why are you doing things? Being able to identify the warning signs of a possible relapse. What are your triggers? What gets you going? Do you know those things? Even if you're not addicted, do you know what triggers you to get angry or sad or upset with people? These are good things to know just to be a good human being. So I will be also giving you this so that you could identify, there we go. One of the things that you do once you identify triggers, you identify the warning signs, things that create stress in your life that could possibly trigger a relapse. Create general coping skills. What do you do when you're stressed? Okay? Some people say, oh, I like going to the beach. Fantastic. What if you can't get to the beach? You need to have plan A, B, C, D, and E. Okay, if you can't go on people, create these big things. Oh, well, I can go on vacation. Yeah, but you can't always go on vacation. What can you do to deal with your stress right now? Okay, I can learn how to meditate. Now, that's something you could do anywhere. That's a good idea. How about, I could read. Okay, that's good. I can play a game. I can call up my friends. That's a great coping skill. Irrational thoughts, keeping track of those. Keeping track of your irrational thoughts. Unmanageable feelings. Feeling management strategy. So when you're feeling humiliated or embarrassed, or if you're feeling angry, what are you going to do? Take a walk, deal with those. Self-defeating behavior. When you get into your victimhood, you can't get yourself out of there. And constructive behavior. So how do you take a break? I will be providing you all of these links. You guys did a really great job this week. I will be posting the All-Stars, and I will talk to you next week when we recap week 6. Everybody have a wonderful week, and if you need anything, give me an email. Shoot me an email, shoot me a text, and I'll get back to you right away. Have a great week. Bye-bye.